Hello and welcome to part 2 of the Pediatric Oral Health Advocacy series. This next presentation will discuss measuring and assessing oral health. My name is David Avenetti. I am an associate professor and the department head in the Department of Pediatric Dentistry at the University of Illinois, Chicago. In this seminar, we have 4 main learning objectives. The first is that you all will walk away understanding how we define oral health and different ways that we can measure oral health along with the pros and cons of each. The second will be how do social determinants and access to care affect oral health? The third is what are factors that are currently affecting the landscape of individual and population healthcare changes. So what's going on in dentistry, what's going on in medicine that's changing the way people utilize and receive care. And we will finish up by talking about how these factors affect advocacy and policy priorities to promote oral health. To begin, we're going to discuss the question, what is oral health? As oral health care providers, we are all obviously trying to work towards this goal, but whether we are meeting that goal really depends on how we define and measure it. So let's take a moment to think about different ways that we could measure this and perhaps what some of the strengths and weaknesses of those various ways of measuring it are. So oral health epidemiology is defined as the way we measure the distribution of burden of disease within a population, specifically related to oral health. And some examples of things that we measure are 2 things really, access and disease status. Within access, some things that you can explore are continuous enrollment in dental benefits, Medicaid for example. A second would be what percentage of individuals had at least one encounter with a provider, an oral health care provider, in the past year. Other ways would be specifying types of procedures that someone received, such as how many people received a diagnostic or preventive visit in the last year. As you can imagine, there are likely strengths and weaknesses for each of these. The second would be measuring disease status, and this is likely what you are most familiar with. I'm going to go ahead and skip over oral health related quality of life to begin, but one way that we can measure is pain. So a person basically stating that they are pain-free or stating that they have pain on their teeth would indicate that something is likely wrong. DMFT versus in primary teeth versus in permanent teeth. You'll see these classically in various published articles. These are not often used on a population surveillance type approach, but they are used for research purposes. Percentage of people that have decay and percentage of people that have untreated decay. Percentage of people that have at least one sealant on a permanent molar, as well as partial or complete edentulosum. So let's attempt to answer the question, what would be the strength and weakness of measuring oral health using some of the examples provided under access? Thinking about continuous enrollment in Medicaid, one of the strengths is that we want people to have access to dental services. So enrollment in Medicaid would suggest that they could potentially schedule appointments without barriers. However, just because someone is enrolled in Medicaid does not necessarily mean that they are seeking out or receiving those services. One of the terms that's used in the Medicaid system that describes people falling in and out of the system is churn. So during COVID, one of the things that many states tried to do was basically minimize the barriers to falling out of Medicaid, and more people were continuously covered. A second would be individuals with at least one encounter with a provider in the past year. One of the benefits of this is that it does show that someone is actually seeking or receiving services. However, the third example, receipt of a diagnostic or preventive visit, is beneficial because we do want people to know their status and hopefully receive some preventive services. However, if caries is diagnosed or other oral health needs, this does not reflect whether those needs have been met. For example, a child receiving a stainless steel crown or a restoration in a tooth where cavitation is noted. As we think about the ways we measure disease status, let's discuss pain. As we know, pain may not manifest in teeth until a cavity or decay is quite deep and approaching the nerve. So the challenge with using pain as a metric is it often reflects a late disease state. Moving on to DMFT or DMFS, as some people may choose to measure, it's very beneficial. It provides very specific data. But that is often something that's not extremely relatable to the general population. So that's a very specific measurement that we use. Untreated decay is a really helpful way of measuring because it's significant for reflecting access to care. We want children who receive a diagnosis to also receive the care that they need. So that is one of the benefits of untreated decay. Percent of patients with at least one sealant. This is often criticized as a poor measure of oral health because one might ask themselves, don't we want patients to have sealants on all of their molars? Why are we qualifying someone as having sealants if at least one of their molars has a sealant? But this is often used as a marker to signify access to preventive services. So it is true that ideally we would have well-placed sealants retained on all at-risk surfaces and molars, but this is often used, as I mentioned, as a metric for access to care. Partial or complete edentulosum is a common approach. The number of people that you basically have any teeth, later in life versus how many people have a full set of teeth, have not lost any. And we're going to come back to the top one, which is oral health related quality of life. This is widely published, and some people might argue that this is really the most important thing that we are trying to achieve. We want people to have a functional occlusion. We want people to be able to function, chew the foods that they want, while also being pain-free and liking the aesthetics of their smile. So oral health related quality of life is in many ways a great measurement of oral health. And when you look at the definition of what oral health is, this really encompasses a lot of that. I'd like to take a moment to really look at the definition of what the World Health Organization uses to define oral health. And you will see that many of the elements we discussed in the previous slide are captured here in this definition. Oral health is the state of the mouth, teeth, and oral facial structures that enable individuals to perform essential functions such as eating, breathing, speaking, and encompasses psychosocial dimensions such as self-confidence, well-being, and the ability to socialize and work without pain, discomfort, and embarrassment. Oral health varies over the life course from early life to old age, is integral to general health, and supports individuals in participating in society and achieving their potential. So really, you'll see all of these elements show up in the previous slide that we mentioned. But I think one of the points that I want to bring home is that no one measure by itself is going to be sufficient. We really have to look at a number of factors if we are deciding whether we have a population that has optimum oral health. I'd also like to reiterate the point that we must not only pay attention to access and utilization to health services, but the distribution and presence of disease within individuals in a population, which is disease epidemiology. Many of you may be familiar with this concept of the core functions of public health. In this figure, you see on the outside that the core functions of public health involve assessment, policy development, as well as assurance. with components built into each of these. You can really start this process anywhere, but let's go ahead and start with the box on the top, which states that as part of assessment, we assess and monitor population health. Well, in order to assess and monitor, you really have to have a way of quantifying and measuring. And that is really one of the themes of this presentation, is that we have to decide how we are monitoring, how we're measuring, and then as we move on to this second part that says investigate, diagnose, and address health hazards and root causes. So this assessment component is very important because it provides data in this next portion, which is policy development. Under policy development, our goals are to communicate, to inform and educate, strengthen and support mobilized communities and partnerships, moving on to creating champions and implementing policies, basically putting things into law through legal and regulatory actions. So through policy development, then we roll that out, and we hope to ensure equitable access, building a diverse and skilled workforce that will therefore deliver and improve and innovate through evaluation, research, and quality improvement, so that we can build and maintain a strong organizational infrastructure for public health. So really, it's measure how things are going. With that data, inform policy development, roll that out to the population, and see if that is making a difference. And then we get back to the beginning of the circle, which is after those changes are made, did it make a meaningful difference or not? And at the core of this, we are assuming that we are providing healthcare in an equitable way. In this next section, we are going to discuss health equity and health equality and what the difference is. This is going to be explored in much more detail later in the advocacy series, so I'm going to use some figures that many people have likely seen before. In the figure shown below, or some version of the figure shown below, which many of you have probably seen before, we can think about these individuals trying to get the apple. Let's use that as a metaphor for achieving a state of health, overall health and oral health. The problem is that we want everyone to reach that same goal, but barriers do exist that prevent people from reaching that goal. Equality means giving everyone the same amount of resources, assuming that it is going to get them that goal. So an example would be perhaps everybody gets a $500 check in the mail, thinking that that is going to make a difference for everyone. You'll find that for some people, perhaps that $500 is not nearly enough to do whatever they need to do. Well, you might have other individuals that do not need that $500 at all in order to achieve that goal. On the right side, however, is where we see equity, and that is giving people what they need in order to reach that end goal, which is health. So you will see that there is a difference, right? You have one individual who is receiving more resources. You have one individual who's receiving a moderate amount of resources, and one person that is receiving few resources, but they all end up achieving that same goal. One other problem with this image that was brought up in a previous lecture is that this also assumes that because you give someone a box, they will use it, which gets into the idea of health behavior. So again, just because you make resources available does not mean that people necessarily engage in a particular behavior of interest. Here's another version of that same picture. What does a bike have to do with oral health? Well, support for health equality versus health equity really involves fundamental differences in belief systems, and there are some difficult decisions that need to be made about resource allocation. So naturally, even some people who are likely listening to this presentation might feel the definition of fair would be to give everybody the same amount, while someone else might define fair as giving people what they need to all achieve the same goal. And that's beyond the scope of what we're presenting here, and likely aligns in some ways with your values, political beliefs, etc. But one of the things that we have to do is understand through research who exactly needs that bike. So you'll see on this top image, everybody got the same bike. And, for some people, that bike works really well. For other people, it's not exactly what they need. So in this lower image, you will see that there's different modifications of that bike in order to all give them what they need to move from point A to point B. So, as a researcher myself, what I want to know is who needs what bike, what specifically will help them achieve that goal, and we cannot assume that it's a one-size-fits-all approach for everybody. I was intentional here in making sure that I included all of the images that you all have probably seen before in various lectures, but what we want to look at here is what is the role or function of social justice in relation to the conversation we just had. So instead of focusing on who needs what, instead of focusing on, what size ladder does someone need, or are they getting a ladder that is tall enough, the direction is really moving towards understanding what is the upstream problem that is leading to the inequality in the first place. Meaning we can continue to provide people with ladders so that they can reach the apples, or we can ask ourselves, what is it that is making these apples unattainable without the use of some size ladder? And that is where we get into this concept of social justice. So I like this picture because you'll see on the bottom here, that the tree is leaning one direction, which gives the person on the left an unfavorable advantage. However, if we can sort of straighten things out and minimize those underlying problems, we can hopefully reduce health disparities. By now, many of you might be familiar with some examples of health disparities, but by definition, a health disparity is a preventable difference in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So one of the key pieces of this definition is that you have to believe that health disparities are preventable. That is, having a sense of self-efficacy that we can make a difference with addressing health disparities. Some of the examples we see in data, even our most recent data, is that there's, of course, differential caries rates among Native American, non-Hispanic Black, and Black African American with regards to many oral health metrics, particularly caries. Not only the presence of caries, but also untreated caries. The second would be higher rates of tooth loss and periodontal disease in lower education systems, so less educated adults. The third being lower healthcare utilization among people with low socioeconomic status, even after controlling for dental coverage. And when we use the term controlling for, we're basically saying that there is some other factor that affects the relationship between those two variables. So we have to take the impact that has on that relationship out of the equation in order to test the true relationship between those two factors. So if we really want to know about the relationship between SES and healthcare utilization, through our research, we have to be able to control for a number of other factors. Naturally, you will see that, the concepts of health disparities often lends itself to this next portion, which is social determinants of health. What are social determinants of health, and why do they matter as it relates to health disparities? This is something that many public health researchers and behavioralists are exploring to better understand social determinants and how we can address those as a means of reducing health disparities. So we know that Dr. Ramos Gomez went over these social determinants of health in pretty good detail in part one of this lecture series. So we are revisiting this at a very broad level in this as a mechanism for framing the next things that we're going to discuss. But as a reminder, the definition of social determinants of health is the conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So if we look at this image here, we see that social determinants of health in this particular thing is shown to be influenced by the healthcare system, the economy, so the resources financially that we have available, the neighborhood and the physical environment. So, do we live in places where it is safe to go outside and perform tasks of daily living, going to the grocery store, exercising, going to the park? Do we feel comfortable parking our cars on the street and doing things as a family? Moving on to the education system, as well as access to healthy foods. Social and community context is related to the way we interact as individuals. Do we have social support? Do we have social networks? And that's where some of the elements in the definition come in, such as where we work, play, and worship, recognizing that we are not just individuals. We are individuals within families, and we are families within communities, and communities within a broader structure. So we have to think about the way each of these levels really interacts with one another. Here we see some of the specific examples that we mentioned before, which is, thinking about economic stability. Are people employed, receiving income? Are they able to manage their expenses and pay medical bills if they incur them? Are they able to pay for support that they need to help their family succeed? The second would be looking at the neighborhood and physical environment. That is, do they live in safe housing? Do they live in appropriately sized housing that allows for sanitation, access to transportation so that they can get to and from school, to and from work, to and from healthcare? Do they feel safe? Do they have access to parks and playgrounds, not only for physical health, but also building strong relationships? Thinking about the education system, do they receive an education that promotes literacy, language development, gives them skills and resources needed to enter the workforce, vocational training, so that they can not only find jobs but succeed in their jobs, as well as have the opportunity to pursue higher education if that's appropriate. I only say if that's appropriate because, as we saw, I guess probably 5 to 10 years ago, there was this large push that everybody should go to college. So you saw a lot of these quite expensive private vocational schools popping up and charging people a lot of money. And unfortunately, these schools advertised that they were able to place their graduates with a high percentage rate and that they would be able to pay off their student loans without any challenges. The federal government cracked down on this and actually found that these schools were falsely advertising the rates of employment after graduation. So I guess where I'm going with this is that higher education does have a cost, and there has to be a cost-benefit analysis that everyone makes when deciding to pursue additional education. As we think about food security, access to healthy foods, do people live in food deserts in which they don't have appropriate access? What does the community and social context look like? Do people feel socially integrated? This is really relevant in the midst of, as we theoretically come out of COVID, even though we know that COVID is probably here to stay in some capacity. But this lack of social integration with one another, lack of community engagement, high levels of stress, and exposure to high levels of violence and trauma. Within the healthcare system, thinking about who has health coverage, are providers available in a timely manner? Are they able to provide care in a way that families can interpret that information and make healthcare decisions? And does this promote quality care? So quality is really defined by a lot of factors, and that's probably a whole nother conversation that I'd be happy to come back and have. But the outcomes that we measure are things like mortality, morbidity, life expectancy, healthcare expenditures, health status, and functional limitations. You'll often find that the some version of the social ecological model is used to explore um, social determinants of health. And that is because we, of course, have an interest in the individual, individual education, income, attitudes, beliefs. But as I mentioned before, this individual exists within a household, within you know, within some other unit, and those relationships become very important to explore. Those relationships with family, peers, partners, and other social networks, because this is how people do sometimes access healthcare information and make healthcare decisions. As we extend that out, we have to look at the communities in which these individuals and households exist. So that's exploring neighborhoods, schools, workplaces, and other organizations that people where people congregate. On a very broad level, we can look at this as a state or federal thing, but what are the societal, social, cultural norms, and what are the policies that affect these? So the social ecological model has many different layers, and you know, a lot of times interventions will focus on one aspect of this, but the evidence is suggesting we really need to have a multi-level model and look at the interactions between these different components in order for interventions to succeed in improving overall health outcomes. At this point, we are looking at different versions of kind of the same information, but I wanted to include this figure so that you are familiar with the World Health Organization definition of how they see both social and structural determinants. And I like the way this figure breaks down kind of what some of the social and structural determinants are and the relationship between those. So again, here in the middle, you'll see that social cohesion and social capital is quite important. So the way that people interact and the way that these different levels interact, with the outcome being equity in health and well-being. So again, going back to that definition of well-being and quality of life. So as dentists, we really like the Fisher-Owens model. This was, created by a number of researchers. It's a very, very well done article for those who have not had a chance to read the full article. But what is this all about? What does it matter? And what does it tell us about how we address oral health? As dental providers, of course, in dental school, we learn so much about this additional layer that's here, and that is within the individual. We're looking at what's going on specifically in the mouth. That's the microflora, the teeth themselves, the substrate, and the diet. So the relationship between these three. And quite often we are so focused on what is going on in the mouth that interventions are focused there. But we have to recognize that, teeth are attached to mouths and mouths are attached to people. So without these more upstream individual, family, and community level factors being addressed, quite often these efforts to address the substrate, the microflora, the host, the teeth, are not sufficient to overcome some of these other risk factors that people face. So as we dig deeper into the kind of micro and meso levels, the individual or classical approach is to look at what factors might be going on at the tooth level, the substrates, and the microflora. And to be honest, there's a lot of effort now being placed on exploring microbiome, and all of the information that we can get from that. And we're going to talk about this a little bit later, but through precision medicine, having an understanding of what's going on in an individual's mouth will hopefully give us information so that we can create very specific interventions that also give consideration to higher levels so that we can develop appropriate interventions that actually reduce risk. Child level influences, something that we care a lot about, are insurance coverage, utilization of that care, the underlying biology and genetics that child faces, the physical and demographic attributes, and the health behaviors. I myself have a strong interest in researching toothbrushing behaviors. And what we find, obviously, is that most children do not have the capacity to engage in high quality toothbrushing without caregiver support. As we dig deeper and take a broader scope, as I mentioned on the last slide, toothbrushing behavior is so important to address at the family level. So the family level influences are socioeconomic status, social support, physical safety, the health status of parents, the family function, the cultural beliefs, and the family health behaviors. So one example that I explore in my own work and team that I work with is really family function. So if you have a family that has multiple children and perhaps it's a single parent, although that parent may have the knowledge and the interest in engaging in oral health behavior, that parent may not have the support needed to carry out those behaviors for all children. And that actually is a common theme in our qualitative work, is that parents will sometimes know exactly what they need to do and have the interest in doing it. But when they make comments like, I get up for work so early that I'm not there to do the toothbrushing for my youngest children, it's the older children that are helping the young children get ready, that becomes very, very challenging. So we have to think about, what type of social support can be offered to this family in order to address those individual and oral risk factors. Then we're going to move into community and beyond, talking again about social environment, the dental care system, the healthcare system. It's also important to recognize that if you only make changes at these outer rings, these outer levels, the hope is, of course, that this will trickle down into these smaller levels, but that assumption cannot be made. Meaning that just because you make a change in the dental system or healthcare system, unless there are also changes within the community and the family and individual, you may not see the effects of those changes manifest. So why does this matter? What we're seeing is there is a greater emphasis on addressing social and structural determinants of health as a means of reducing health disparities. And part of what we're seeing in healthcare is this concept of care coordination. And the goal of care coordinators is to kind of understand the role that social determinants can play and therefore assist families and individuals in making the arrangements for the health care that they need to receive. So care coordinators, social work, similar models are really aimed to understand social determinants to facilitate and help individuals. As we mentioned in a very early slide, one way that we measure and define oral health is through access to care. But, what is access to care? This is, again, a high-level touch on what was presented in part one, or the first lecture of the series, but really thinking about what are the factors that address access to care. The truth is that access to care is really a function of two main things, and that is health coverage and health utilization. So let's take a moment here to think about what are the components that affect whether someone has health coverage, health benefits, and what are the factors that impact whether a person is able to utilize that health coverage. And really, it's the interplay of those two things that address access to care. Coverage is access to obtain dental insurance or the ability to pay. I say that because, dental benefits come in many different forms. That can be going to the insurance marketplace to purchase something. That could be employment benefits. That could be Medicaid or CHIP benefits. And for some people, they choose not to obtain benefits at all and would rather pay out of pocket. But technically, the ability to pay cash for services would indicate that that person has coverage. In the United States, however, the system that we have lends itself to coverage because most pricing models for services are not designed to reflect cash payment costs. So the question is, did the ACA fix our problems? The goal of the ACA and one of the 10 kind of core pieces of it was that children's dental benefits were to be included. What we're trying to illustrate here is that although that coverage was provided under the ACA, that did not necessarily mean that immediately people were utilizing that coverage. Factors that affect utilization really is individual behavior, so parents seeking out that care, but you will see that the workforce has a significant kind of piece of this as well. So we need to have an adequate distribution of dentists and specialty services, recognizing that there are different types of payers, therefore a payer mix, making sure that there is acceptance of Medicaid, which is the coverage that our highest risk population has. And I'm not saying that all high risk individuals have Medicaid, and I'm not saying that all Medicaid enrollees are high risk, but we know that generally just based on socioeconomic status that Medicaid individuals are at a higher risk. Also, dentists who are willing and able to provide timely services. So although a person might have access to a provider, the question is, can those needs be met in a timely way so that the disease does not progress? When we think about the reasons why coverage does not always lead to utilization, it goes beyond the workforce issue. It goes beyond whether there's adequate dentists, and that is many people actually do have moderate to high oral health literacy. That is, they have the knowledge about how to maintain their oral health. We can't assume that just because someone doesn't go to the dentist or receive dental services that they are low knowledge or low health literacy. This knowledge forms attitudes, and these attitudes can be things like trust and belief. So although you might have providers in your community, you have to trust and believe that they will provide quality services for you. So this combination of knowledge that forms attitudes or that contributes to attitudes will then affect behavior. And part of behavior is self-efficacy. So the belief that people have the ability to change the outcomes. So some individuals have a fatalistic viewpoint in which they feel that no matter what they do, they're going to get cavities, or they're going to lose most or all of their teeth by a certain age. So this is part of the reason why coverage does not always lead to utilization, because at the individual level, you may have deficiencies or gaps in knowledge. You may have challenges with attitudes, and those may contribute to certain behaviors that get in the way of them achieving oral health. Areas where we are devoting a lot of attention and investment is with regards to technology. So previously, access to internet or use of smartphone services was limited to certain demographic groups. But what we're finding is that access to internet is no longer a barrier. So why is this relevant to the previous slide? Because this is allowing us to provide education and knowledge in different ways that will then hopefully shape attitudes. Also, the way people interact with the healthcare system, the ability to seek information, to schedule appointments, to engage in healthcare decision making electronically. And as we've seen, telehealth is on the rise. So more than half of smartphone owners have used their phone to get health information or do other daily tasks such as online banking. So we look here at data from the Pew Research Center leading up to 2019. It was previously thought that smartphones were also limited to certain demographic groups, but what we're finding now is that smartphones are essentially ubiquitous. That is, people have access to internet through either desktops, laptops, tablets, or smartphones. So this provides unique opportunities for healthcare delivery, for education engagement, as well as allowing them to interact with the healthcare system. And this really changes the landscape for how people may achieve oral health. Unfortunately, things do happen beyond our control, and for this next few slides, we are going to look at how a natural event such as COVID potentially worsened oral health inequities. This is an area that that got a lot of research, not only in the midst of COVID when rates were very high, because we needed that immediate data to inform policy, but now as the virus is changing, healthcare landscape is going back to what it was before in many ways, but not always. We're starting to get significant data about if and how this worsened health inequities. From a systems level, we found during COVID closures obvious inability to access care. What this meant is that people that were amongst the highest risk groups, so those people that already had caries that were untreated, experienced progression of that disease during the periods where offices were closed. And even after reopening, as you can imagine, the volume of patients being seen was significantly lower. So although many families wanted to re-engage and schedule care, they were not able to do so in a timely manner. We're finding even in our clinics significant numbers of families that have still not reached out to get their children in. We've made attempts, but for other reasons, they're just not coming. I think other priorities have emerged. We also found that because volumes are slightly lower, there's actually few opportunities or appointments to fill. So this is creating a challenge, and we've seen the number of people in our area that are willing to accept Medicaid decline in total numbers, as well as the percentage of children seen under Medicaid decline. So this is overburdening certain safety net clinics, and this change in the number of Medicaid providers initially in the literature that's coming out is described as increased cost of PPE and the inability to have the same number of patients seen, so a lower throughput of patients. Unfortunately, people who access services through many school-based programs have either not seen those school-based programs resume fully or have not seen them come back at all. So school-based programs are designed to reach patients in higher risk or people that do not have regular access to care. In the thick of COVID, we found people were obviously very afraid of going on public transit, and even now when we talk to some families who face transportation issues, they report fear about taking public transportation. Those systems level issues were some of the barriers that increased during COVID, but we also see some barriers that rose at the family level, and that was housing and income instability were much more prevalent. Individuals who previously had employment-based insurance, many people lost that insurance as they became unemployed. Some children who received food through school-based programs no longer had that food security. Although some schools did maintain programs where families could stop by and pick up foods, that food insecurity was quite quite prevalent. And families were reporting going through their food much more quickly, given that more people were at home. So some of the policies around number of caregivers for appointments has maintained as we've come out of the worst rates of COVID. So many clinics still only allow one caregiver, and that may be quite disruptive for families depending on how they approach scheduling and attending their appointments. And many people, this is from our own qualitative research, had a low understanding of risk mitigation. So, there were lots of rules being applied, but people did not understand how or why those rules were in place, and did not necessarily believe that they would effectively reduce rates of COVID. So I think in nearly all geographic areas, we've already discussed disparities, but what were some of the disparities that revolved around COVID? We talked about some of the oral health disparities, but you also saw in many news outlets and initial manuscripts that the deaths from COVID, there were significant disparities there, as well as the distribution and receipt of COVID vaccines. One of the key goals of this lecture is to, obviously talk about what is oral health, review the essential functions of public health, and look at oral epidemiology, thinking about the differences between individual and population health, as well as thinking about how we identify and execute oral health priorities. So thinking about how we identify oral health priorities, let's think about what are some changes from COVID that we think are here to stay and that will continue to shape our healthcare system moving forward. When the ability to provide traditional services, that is restorative aerosolizing procedures, when there were limitations around that, we saw an uptick in something that had been discussed for a long time in dentistry, but had not really stuck, and that was medical management of caries. So this was very much a natural experiment where individuals were forced to think differently about how we manage caries. We were doing things like, silver diamine fluoride application, more prevention, or doing things like sedative fillings rather than the traditional crowns, placing Hall crowns instead of traditional stainless steel crowns. So although that's not all medical management of caries, we did see a rise in medical management of caries as well as conservative therapy. And what is being presented is that much of that actually worked. So many individuals who felt uncomfortable with some of those techniques before COVID indicate that they plan to keep those as regular practices in their offices and healthcare settings. Teledentistry was also something that has existed, actually, telemedicine particularly has existed for a long time, but there was not much of a need pre-COVID to use it. So that was really a natural history experiment that showed us how and where and why teledentistry might work. It is promising in terms of reaching patients in rural areas, and also promising for particular types of encounters, such as screening, triaging emergencies, motivational interviewing, basically education and follow-up on behavior. However, literature suggests that the clinical management and diagnosis can be limited by teledentistry. However, even in our clinics, we'll have families take photographs, send us a photo. We will call them back and go over our findings on the phone and basically think about the acuity of the situation when scheduling the patient. So teledentistry is definitely something that's going to be here to stay, but now insurance companies are having to figure out how and when and for whom they are going to pay for these services, because unless people are compensated for the time, the technology, it will likely basically fall off a cliff. Another thing is enhanced PPE, although enhanced PPE, or rather, although PPE has the requirements have significantly reduced. Many people report that they will do things like regularly wear masks throughout their offices at all times, continue to wear face shields or wear N95s in the operating room. So this is going to continue to be an additional burden and cost, but people feel safer through this enhanced PPE. Due to COVID, the cost of healthcare significantly increased. That was related to a few things. First, not only the direct cost of care for people affected by COVID, as well as the worsening of concurrent or chronic conditions, but also the number of people that were enrolled in Medicaid increased by 4 million. This is a little bit older, so that number has actually increased to roughly 6 million, whereas we have 80 million people in the United States covered under Medicaid. Overall, we are finding the rising cost of healthcare in the United States to be extremely rapid, and this begs the question, is our healthcare system sustainable? So bringing this back to the overarching theme of this presentation, how do we measure and assess oral health? One would expect that the more expenditures there are on healthcare, you would see a similar improvement in the disease status of individuals. However, that is not the case. So one common way to evaluate the expense of a particular area is to look at it as a percentage of gross domestic product. What you'll find is that when we look at health expenditures, and these figures with the dashed line were actually taken just before COVID, you see that healthcare was probably around the range of 17% of GDP. Just over 10 years ago, when we look at 2010, it was at about 16, 17%. And then back in roughly 2000, we were looking at less than 15%. So theoretically, you would expect the percentage to be relatively stable. So this projection shows it increasing, and it was estimated to approach nearly 20% in the year 2028. As you can imagine, because of the costs related to COVID, there was a significant bump in the actual number, which therefore increases the projection, whereas the actual expense of healthcare in 2019 was around 20%. Where people get concerned is when you ask yourself, does that cost for healthcare offer a meaningful return on investment? And how do those expenditures compare to other industrialized nations? And do other countries invest a similar amount of money and achieve the same rates of health? And what we find is that in the United States, administrative costs comprise a larger share of healthcare spending. So basically, we spend a lot of money on the administration of healthcare in the United States, whereas other countries, many other industrialized countries, are roughly at around like 5 or less percent. We'll discuss the administrative costs in more detail, but one particular thing to note is many people are afraid or hesitant to enroll as a Medicaid dental provider because of the administrative hoops that they have to jump through in order to get signed up. They're also finding that they need to sign up with more companies that are administered within the state in order to see patients. On this slide, we look at the U.S. per capita healthcare spending. So that is the amount of money spent on each individual. And what we find is that it is roughly twice the average of other wealthy countries. So Switzerland, Germany, which are generally known to have relatively good healthcare systems, and what is spent, whereas the average is around $5,500. So we spend a lot of money, and many people argue that we don't have very good outcomes considering that we spend this much on each individual. So we have to think about what is contributing to the rising cost of healthcare. And although these last few slides have focused on the healthcare system as a whole, um, of course, we're concerned about oral health and its role in the larger healthcare system. But really, what is driving that to be more expensive? I've created a short list of items here. This list could be much longer, but when you look at news outlets and you read the literature, look at data, high administrative costs, which we've talked about, roughly 8-9% here in the United States. And although, specialization, whether it be in medicine and dentistry or another field, although specialization has its benefits, uh, many people report that that is leading to a fragmented system and creating inefficiencies. So someone who has a chronic condition might need to see their primary provider as well as 3 or 4 other specialists to have their care managed, where previously they might have only seen perhaps a primary care doctor and 1 specialist. There's also some thoughts that student loan debt is being passed on to the end user, and the end user are the patients that we serve. So because dental school is quite expensive, averaging I think roughly $250,000 for a 4-year program, the decisions that graduates are making in terms of the types of practices that they work in and what they are charging for their services is higher than what we would see if student loan debt were much less. Many people argue that there are significant inefficiencies within our systems, and although our technology should lead to more efficiencies, the health informatics is not necessarily working in the way that we would expect. We also have a structure where we are compensated for procedures. So for everything that we do, essentially we are paid more. This incentivizes people to do more. But what we're going to see probably is that, and we're going to talk more about this later, is a shift towards quality-based compensation structures. That is value-based care, where we are compensated only for doing the things that seem to matter and make a difference. Medical supplies are also quite expensive, as well as the cost of pharmaceuticals. So if you were to buy a nice, shiny new radiology machine, this unfortunately drives the cost of the services that we provide that rely on that machine. So there's kind of this ratchet effect where one thing is driving up the cost of another, and that's going back and forth. And when you look at the expenditures for individuals early in life and end of life, we have the technology to sustain or rehabilitate people that otherwise previously would not have seen as people who could be rehabilitated. So the expenditures in the first couple of years of life, as well as the late years in life, is quite high. In order to achieve oral health, we have to think about the role that these costs, as well as dental insurance and understanding dental insurance, play. So most people have one of, let's say, 4 types of dental coverage, dental benefits. That is employment-based insurance, where your employer basically pays a portion of that, you contribute. The second would be through federal state partnership services, so Medicaid or a children's health insurance program. The third would be going to the marketplace, which was rolled out with the Affordable Care Act. And then you also have people who pay out of pocket for those services. For just about any type of insurance program, or most insurance programs, there is some type of cost sharing in which the patient or the family makes a portion of the payment. And that can look a lot of different ways. You can, of course, pay a monthly premium where, for $60 a month, you're paying for dental care for your family. But one way to mitigate costs is to have an annual deductible. And those deductibles can be separated by services. So you might have no annual deductible for preventive services, but you might have a deductible for let's say, restorative services. This is frequently termed co-insurance, where basically co-insurance is where you pay a portion, a flat rate, so 5% of a particular service up to a maximum, or you can pay 10% or 15%. So no matter what, you're paying a percentage. Co-payment is where you make a flat payment. So let's say $500 for an emergency room visit, or $5, $10, or $20 for a dental visit. These will often have annual maximums where anything beyond that, it is not up to the family. And that really protects the family from catastrophic events, so things that are exorbitantly expensive. And you can go to the news and hear a lot of stories about people who have been driven into bankruptcy because of the cost of healthcare. If you stick with one insurance provider, you will also see sometimes that there are lifetime maximums. We see this with orthodontics. So an orthodontic company might say, I'm covering orthodontic benefits up to $2,500 for the patient's lifetime. And we expect the family to make 50-50 contributions for, let's say, orthodontics until that maximum is met. So if the cost of ortho is, let's say, $4,000, $2,000 of that will be paid by the patient, $2,000 will be paid by the insurance company, and $500 will be remaining for orthodontic services later in life. So fee schedules are often set, and insurance companies have negotiated rates for the services that they provide. So what you'll find is that many providers are choosing not to participate in these insurances because they are getting frustrated by the administrative burden as well as the fee schedule negotiation. So they are essentially saying, I am going to expect my patient to pay cash for their services, and then they can go back to their insurance company and recoup what the insurance company is willing to pay them. This interest in being fee for service is widening kind of the disparity gap because it's seen as a more exclusive approach to delivering oral health care. I'd like to highlight this classic RAND study. So the classic RAND study, it basically showed that if somebody has to contribute to like paying a co-insurance or co-payment, no matter what the cost, that it can disincentivize people from seeking care. So that is particularly important when we think about diagnostic and preventive services. You do not want to discourage people from seeking diagnostic and preventive services. Some of the challenges that arose out of the Affordable Care Act, it was designed to address many of these healthcare concerns, but some of the challenges that came out of the ACA was that, theoretically everyone was supposed to purchase insurance, but was that actually required? Were people penalized if they didn't? Of the plans available, we often found that people would go with the less expensive monthly plan, but these plans also had a higher deductible. So it might only cost them, I'm just going to throw out any number, let's say $50 a month, but they would essentially have to pay up to $2,000, $3,000, $4,000 before any of those benefits kicked in. So this disincentivized them to seek care. Unfortunately, prevention was bundled into the cost sharing, so they had to pay the co-insurance on prevention as much as they did the other services. And we found that dental was embedded within medical, so they were not purchasing separate dental and medical in many of the plans. So the real question is, now that we have some understanding of the various challenges that we're facing, how do we affect change? And it's very easy to feel as an individual like you have no control over the situation. But the truth is that we do. We can all be advocates, and it is through our advocacy efforts that we affect change with policy. So take a moment to think to yourself, what is the difference between advocacy and policy? And how does this differ with the term public health? Well, advocacy is really the activity. So it's an activity by you as an individual or a group of individuals, such as the American Academy of Pediatric Dentistry, that aims to influence decisions within political, economic, and social systems and institutions. So you can be an advocate for an individual, you can be an advocate for a group, you can advocate at the individual level, the community level, the state level, the federal level. There's lots of different ways that you can do this, and I think one of the key takeaways here is that it is through coordinated efforts that we are able to affect change. So don't feel discouraged. I want to make sure that everyone feels some sense of kind of self-efficacy and the ability to make a difference. So the document put forth by the AAPD, it's kind of an advocacy toolkit that talks about how programs can teach advocacy within residencies. Does a great job of breaking down different levels of advocacy. So individual, local, state, and national, as we just talked about. Think about what some examples might be. Individual advocacy would be, let's say you have a child with special needs in your clinic who needs operating room services, but an insurance company is requiring a letter to support the general anesthesia. Well, you as a provider writing a letter of justification or explanation is really being an advocate for that individual, or getting someone in touch with social services or community, let's say social work. On the individual level, that is extremely helpful for the patient. At the local level, we see people get involved in school-based programs, get involved in their communities. There's really a lot of options. And then the more traditional ways that we think about advocacy are state and national. So a little pearl is that, dental licensure is administered at the state level, and Medicaid fees are administered and determined at the state level as well. So if you are concerned about what you are compensated for, let's say for sealants, in some ways that is a national issue, but in most ways, basically, that's something that needs to be addressed at your state level. Whereas when we think about national issues, thinking about some of the things that the AAPD has focused on recently, there are specific issues that must be addressed at the federal level and are more federal issues than state levels. If you go to the AAPD website, you will see what some of the key advocacy issues are under their legislative priorities. I've listed a few here. These are not all the most current ones. I've put these forward so that you've seen historically kind of what has gotten some attention in the last 5 to 10 years. One of the key advocacy issues for APD was revisions to the Affordable Care Act, general, revisions to the healthcare delivery and payment system. So that would be like McCarran-Ferguson Act, or ensuring that patients with craniofacial defects are covered for the services that they need. They're seen as medical and not dental. Systems level issues like dental education and faculty shortages. So one way to address, faculty shortages and the role that they have in dental education is through federal support for loan repayment programs. Regarding the pediatric dentistry workforce, some issues is making student loans tax exempt during residency training, so you're not continuing to accrue interest, because we know that student loan debt can really affect the decisions that graduates make in terms of how and where they choose to work. So annually, these, or rather a few issues, are identified as our key legislative issues, and we go to the Pediatric Oral Health Advocacy Conference in DC, where we advocate with our state representatives after learning about these issues. When we ask the AAPD membership what are areas of concern for you right now, two things that continue to come up are differentiating pediatric dentists from general dentists. So how people are advertising as specialists or not. And also this general trend in healthcare where we're seeing more DSOs come up. So what are the impacts of that? So those previous issues were advocacy issues that we face in pediatric dentistry. But now we're going to shift gears and say, what is the difference between advocacy and policy? And at a basic level, you can think of policy as how things are legislated. So kind of the laws, the regulations, the actions that change as a result of advocacy efforts. So these are often done within governmental institutions or agencies. So policy involves legislating a decision so that we can promote health. And when we go back to kind of the core functions of public health, we think about what we mentioned where the assessment component is important. But then we have to use that assessment to inform policy. And based on those policy changes, and we roll out those changes, go back and determine through gathering additional data, did those policy efforts actually have the intended effects? For people who conduct policy analyses, it's actually far more complex than you would think. So the common saying is, if you think a solution to a problem is easy, it means you probably haven't thought about the problem long enough. Another question that comes up is, you really have to make sure you agree on what the problem is before you start thinking about solutions. And quite often you will get different opinions about what the actual problem is. And I think that's actually a life lesson. Before you try to fix the problem, you have to agree on the problem. The second question to ask yourself is, is the problem a local, state, or federal issue? Because if you want to advocate and lead to policy change, you have to make sure that you are addressing it at the correct level. The next question is thinking about who the stakeholders are. So a policy decision, you might go in wanting a particular change to help patients, and you think about how that might affect you. But there are typically more stakeholders or affected or interested parties involved than just two. So you have to think thoughtfully about that. And ask yourself, is it the appropriate time to pursue a particular issue? Thinking about the political and the economic climate. So if you go to, let's say, Capitol Hill regarding a certain problem, and it sounds very tone deaf for you to be talking about that because there are other much more significant issues, that may not be the proper time. Also thinking about policy options. So you always have to think about more than one option to fix the problem. And with each of the options, thinking about what would be the intended and unintended consequence if that proposed solution or option were implemented. Because the truth is all solutions have intended consequences, things that we want, and they will also have unintended consequences, side effects, things that we don't want. So really, you have to do an analysis and determine what is the best policy, thinking about the cost and feasibility. Quite often, options are great in theory, but based on the tremendous cost involved with them, or low level of feasibility, or inability to have any oversight, they may not work. So policy analyses are really complex. There are people that spend their entire career on these types of issues, and this hopefully provides a roadmap of things to think about. So moving away from the more abstract idea and into a specific problem, let's think about ourselves as oral health providers. We know that sugar-sweetened beverages cause cavities. We also know that sugar-sweetened beverages contribute to obesity and diabetes. So when there was a big effort to kind of reduce sugar-sweetened beverage consumption, this in the dental field was great because we were hoping that this would also have positive effects on reducing caries. So what is the problem? Basically, people arrived at too much consumption, too much accessibility of sugar-sweetened beverages for young children. And when thinking about whether this is a local, a state, or a federal issue, the truth is that it was a little bit of each, right? Because the corn syrup is used instead of cane sugar for many soft drinks in the United States, and corn syrup comes from corn. So a lot of farming is subsidized by the federal government, therefore it's a federal issue. However, at the state issue and or state level and local level, a lot of taxes, and including beverage taxes, are administered and those funds are distributed more locally. So when we think about stakeholders, I think healthcare providers are stakeholders, patients and families, the ones who we're hoping to help, are stakeholders. But there are so many other moving parts, such as the beverage industry, the distributors of the beverages, the people that receive tax benefits from the sale of these sugar-sweetened beverages. So that kind of paints the picture that the problems are typically far more complex than we think, and we have to consider those when proposing issues. So if the problem is too much sugar-sweetened beverage consumption, we then have to think about what are policy options if our goal is to reduce the consumption of that. A few examples of things that have been implemented are the banning of sugar-sweetened beverage sales in particular settings, such as schools, hospitals, or other government buildings. The second option that we've seen quite a bit is a major tax hike on sugar-sweetened beverages to the point where they become extremely expensive. So a third thing would be to promote an alternative, such as increasing access to and increasing the messaging around healthy water consumption. So many people might be fearful of water. They're afraid to drink it out of their tap. So if we are able to provide good, clean water and let people know that it is safe to consume, the question is, would they consume that instead of sugar-sweetened beverages? So that's where we have to think about what is the best policy with regards to cost and feasibility, and what would be the intended and unintended consequences of those. So thinking about ourselves as advocates with an interest in affecting policy around dental Medicaid, some of the problems that we face are, there's a relatively high percentage of pediatric dentists enrolled as Medicaid providers, but there's a very low number of meaningful use providers. That is, the number of dentists who actually see above a certain threshold of Medicaid patients in a particular year. That number is not very high. So what you find is let's say a few people or a few offices or within, let's say, a state are providing most of the Medicaid services. We find that there's major disparities in the compensation for Medicaid. That is, some states compensate quite adequately, while others are very poor in their compensation. And the way that these are often assessed is you have usual and customary fees for most services. So the Medicaid reimbursement is evaluated based on a ratio of that reimbursement to the usual customary fee or usual customary reimbursement. So some states are often at 20 to 25 or 30 or 35% of usual and customary fees, where other states get very, very close to or get much closer to a particular rate. There is also a reported high level of administrative burden, so filling out the paperwork, getting enrolled as a provider through the Medicaid agencies in your state, and also some unfavorable characteristics such as high failure rate among Medicaid patients or higher failure rate, the social perception that if I am seen as a Medicaid provider, that's stigmatizing, the understanding that there's increased disease burden in this population. So some providers may feel they don't have the capacity to accommodate those resources. And a more recent concern has been fear of audits. So people don't want to make mistakes under the Medicaid services because they're afraid that they might get audited and essentially have to pay that money back. So fair auditing practices has been a big advocacy effort from the AAPD. One of these topics is kind of the future of health and how we are going to be compensated for the services that we provide. As I alluded to earlier, historically we are compensated for exactly that, the services that we provide, so there is an incentive to do more. Well, this concept of value-based care kind of goes hand in hand with what was previously called the triple aim. And that triple aim is we want to achieve population health, meaning we want to get people healthier. We also want to decrease cost while also improving the experience of the patient. So doing all three of those things at the same time has been a long-standing goal. But we do know that this comes with administrative burden. It's very hard to do better with less time and less money. But one of the challenges with the triple aim was that we lost sight of the provider, right? It's like, okay, we're trying to achieve health, keep costs low, and provide high quality. What impact does this have on the provider? So we are also having to think about provider satisfaction and provider burnout. But also with value-based care, really a focus on making sure that we are doing things that show that they make a difference. So part of doing things that makes a difference is having sufficient evidence and creating best practices in evidence-based care, and actually following guidelines to only perform tasks and functions that have a proven therapeutic effect. So really, as a provider, one of my charges to you is make sure that you stay on top of kind of the science and the direction so that your services are meaningful. Thinking about dentistry, one of the funny things is, what do we do that actually has low quality evidence? We universally maintain 6-month recalls for low risk children, or really all children for that matter. Unfortunately, high risk, moderate risk, and low risk children are all sort of rubber stamped the same, and we ask them to come back every 6 months. Where the truth is, very low risk children probably could be seen once a year. Moderate risk children could be seen every 6 months, whereas high risk children really should be seen every 3 months. So if we were really following value-based care, we would have that system in place where we are compensated for seeing certain people every 3 months and required to basically see low-risk children a little bit less often. Other procedures would be something like a rubber cup prophylaxis. There's actually not a lot of good evidence that rubber cup prophylaxis, not including scaling, really makes a difference in long-term oral health. Yes, it removes plaque, but is it worth the healthcare system to pay $40 or $50 for that type of procedure? Whereas other procedures, such as motivational interviewing, education, do have some value and either are not compensated or are compensated very poorly, even though they may take a significant amount of time. So when we think about kind of the future directions of medicine or dentistry specifically, what are we going to see on the horizon? What do we need to be in tune with? One is precision medicine and epigenetics. That is, being able to customize our healthcare based on particular factors present within the individual. Integration with primary care, so interprofessional education, collaborative practice, an increase in technology, therefore health informatics and electronic health record usage by the patients we serve. Probably more care coordination, so people or agencies responsible for helping people navigate and coordinate care in the healthcare system. Thinking more about upstream kind of meso or macro determinants of health, as opposed to just thinking about teeth and the individual patients, and also a move in the compensation structure towards value and quality-based care. To summarize the four main things that we talked about in this presentation, first, we discussed the definition of oral health and different ways that we can define and measure, as well as some of the strengths and weaknesses of each. We then talked about access to care and social determinants and how these affect oral health and why it's important to measure each of these aspects. We then moved on to factors that are affecting the landscape of healthcare at the individual and population levels. We discussed some of the impacts that COVID has had on that. And we finish up by discussing how these factors shape the advocacy and policy priorities that we use to promote oral health as individuals or within organizations such as the AAPD. I want to thank you for your time. Welcome to an amazing profession. We are all very fortunate to not only be healthcare providers, but dentists and pediatric dentists at that. So thank you for your time. Feel free to email me if you have any questions or comments about this presentation.